Now, HIV, AIDS. After this lecture, the student should be able to describe the epidemiology of HIV, uh, particularly in the Philippines, discuss the pathophysiology of HIV, and formulate a plan for testing and initial management of patients with HIV. Of course, I'd like to encourage everybody, if you would like to get additional information, you can read your textbook, latest edition of Harrison's, chapter 20, chapter 208, which provides updates on HIV. This figure will show you the estimated annual new HIV infections among individuals 15 years old and above from 2000 to 2021 globally and in the Philippines based on the UNAIDS estimates. Prior to 2010, the HIV epidemic was described to be low and slow, with about 4 newly diagnosed cases reported every month and a national prevalence of less than 0.1%. While the overall trend of HIV incidence and AIDS-related deaths are declining globally, an increase in new cases was reported to the HIV/AIDS and ART Registry of the Philippines, or HARP, in the recent decade. In 2012, there were only approximately 9 new HIV cases every day. In 2003, however, there have been 46 cases reported daily, a stunning 411% increase in daily incidence in 10 years. Late presentation in care remains a concern, even with 29% of new confirmed HIV cases in January 2023 having clinical manifestations of advanced HIV disease at the time of diagnosis. So, as of June 2025, the Philippines has the fastest growing HIV epidemic in the Asia Pacific region. This time, the number of cases has surged by over 500%. The number of people living with HIV is estimated to be around 252,800 in 2025, up from approximately 190,000 in 2023. Young people at the highest risk, particularly those aged 15 to 24, are at the forefront of the epidemic, with 33% of new infections occurring as of early 2025. The primary mode of transmission is sexual contact, with young, sexually active men who have sex with men identified as a core group for transmission. Now, lifted from the latest surveillance data from the Department of Health, you can see there are around 144,192 cases of new HIV. That's 50% of those who have presumed to have HIV. That's only 57%. Now, among these individuals, only 66% or 95,556 are diagnosed. Now, viral load was tested the past 12 months in only 51,206 with 44,714 virally suppressed, but overall, only 47% are virally suppressed. So you can see that if you look at the target 95, 95, 95, set by the WHO, we are far from behind. For the second quarter, there's an average of 45 new cases per day. 21% had advanced HIV at diagnosis. So as I've said, sexual transmission remains to be the predominant mode of HIV acquisition in the Philippines, primarily among MSM. HIV transmission through the sharing infected needles remains relatively low in the Philippines. It was reported to be highest in 2010, accounting for 9% of all new cases that year. That same year, an outbreak of HIV and hepatitis C virus occurred in Cebu City, where over 50% of PWID were found to have HIV and 93% were infected with HCV or hepatitis C. HIV transmission through infected needles has decreased since 2011 and constitutes around 1% of all new reported cases in the past few years. However, due to the recent socio-political climate, particularly during former President Rodrigo Duterte's war on drugs, it is likely that data among PWID and among those who use illicit drugs remain underreported for fear of legal ramifications. So, simply put, HIV actually means for H, that's human, infecting human beings. I, immunodeficiency, weakness in the body's ability to fight off infections. And V, or the virus, the organism that's capable of living and multiplying inside a living cell. A, acquired, to come into a possession of something new. I, and D, immunodeficiency, decrease or weakness in the body's ability to fight off infections and illnesses. And S means syndrome, a group of signs and symptoms that occur together and characterize a particular abnormality. So, based on this simplified definition, all of us, of course, are familiar with how HIV/AIDS would really manifest, particularly those who have uh, immunodeficiency, and they are definitely very compromised or predisposed to develop lots of infections. And if their CD4 is less than 200, their ability to combat opportunistic pathogens becomes very, very low. So HIV is spread only extremely rare cases by having oral sex. Oral sex carries little to no risk for getting or transmitting HIV. Theoretically, it is possible if an HIV positive man ejaculates in his partner's mouth during oral sex. Factors that may increase the risk of transmitting HIV through oral sex are oral ulcers, bleeding gums, genital sores, and the presence of other sexually transmitted diseases, which may or may not be visible. However, the risk is still extremely low and much lower than with anal or vaginal sex. Can also spread by receiving blood transfusions, blood products, or organ tissue transfers that are contaminated with HIV. The risk is extremely small these days because of rigorous testing of the U.S. blood supply and donated organs and tissues. And you can't get HIV from donating blood. Blood collection procedures are highly regular and very safe. So when you look at, of course, the HIV structure, certainly we have the HIV envelope, and inside it, of course, we can see the nucleus, along with the HIV RNA, HIV enzymes, HIV capsid. No? The HIV capsid is the core that contains the HIV RNA, while the HIV envelope is the outer surface of HIV. So remember that the enzymes of the HIV are the proteins that carry out steps in the cycle or in the life cycle of the virus, while the glycoproteins outside are the spikes embedded in the HIV envelope that makes it more, of course, capable of attaching or attachment. And of course, the RNA is the genetic material, coming from the virus itself. Now, when you talk about the inside or the nucleus, we can see that it has an important enzyme, which is the reverse transcriptase, that somehow is responsible for its replication. And of course, the integrase is the attachment along with the transmembrane glycoprotein, that are also responsible in how this virus is able to attach itself and circulate inside the host that is infected. So now moving to the replication cycle, HIV attacks and destroys the CD4 cells or the CD4 T lymphocyte of the immune system. CD4 cells play a major role in protecting the body from infection. And HIV uses the machinery of the CD4 cells to multiply and spread throughout the body. And this process, which is carried out in 7 steps or stages, is called the HIV life cycle. HIV medicines protect the immune system by blocking HIV at different stages of the life cycle. So, ganyan kalala, no? O ganyan magnificent ang HIV virus, primarily because it attaches itself, to our protective carrier, protective cells. And that's the main reason why the immune system gets affected, particularly when it replicates. There will be an interplay of the various triggers as well as the factors related to its multiplication, leading to, of course, further consumption and further uh, decrease, of course, in the inflammatory cells, as well as the diminished function of our immune cells that would later on affect, our capability against protection, or should I say, with the protection. So following HIV transmission through the sexual mucosa, the viral spread occurs through draining lymph nodes in the bloodstream, spreading to multiple compartments of the body, the brain, lungs, and gut-associated lymphoid tissue. So the amount of HIV in a milliliter of blood after primary infection may reach several million viral particles, and a notable decrease in the quantity of circulating CD4 lymphocytes occurs along with this response. And the generation of antibodies or seroconversion follows the activation of CD8 T cells, destroying HIV-infected cells and almost always accompanied with acute viremia. That's the reason why some of the infected patients may present with fever during this time. And of course, some may also present with lymphadenopathy. So these are non-specific symptoms that may mimic a systemic viral infection. Now, the CD8 T cell response plays a crucial role in regulating viral levels, which peak and then start to fall as CD4 T cell counts increase. Though it does not completely eradicate the virus, a strong CD8 T cell response has been associated with a slower disease progression and a better prognosis. So these three features have both local and systemic consequences, leading to lifelong infection, irreversible CD4 T lymphocyte depletion and dysfunction, and immune senescence and exhaustions. The, of course, ability to infect CD4 T lymphocytes and macrophages, determined by the expression of HIV cell receptor CD4, CCR5, or CXCR4, the establishment of latently infected cells harboring the HIV genome integrated into the chromosome DNA of the cell, and then the induction of immune hyperactivation throughout infection, leading to accelerated immune senescence. So later on, there will be a chronic immune abnormality that will lead eventually to diminished immune response. So for the first 10 days or so, HIV stays hidden. It's impossible to detect or test for, but millions of copies of the virus are already being made in the lymph nodes near the body site of infection. Okay? So when we talk about acute HIV infection, this is the early stage of HIV infection. And it generally develops within 2 to 4 weeks after infection with HIV. During this time, some people have flu-like symptoms such as fever, headache, and rash. In the acute stage of infection, HIV multiplies rapidly and spreads throughout the body. The virus attacks and destroys the infection-fighting CD4 cells, or the CD4 T lymphocyte of the immune system. During the acute HIV infection stage, the level of HIV in the blood is very high, which greatly increases the risk of HIV transmission. A person may experience significant health benefits if they start ART during this stage. Now, for the second stage, this is a chronic HIV infection, also called the asymptomatic HIV infection or clinical latency. So, ito na yung wala silang symptoms o wala silang manifestation. And during this time, the virus continues to multiply in the body but at a very low level. People with chronic HIV infection again, may not have any HIV-related symptoms. Without ART, chronic HIV infection usually advances to AIDS in 10 years. That's a median time period, or longer, though in some people it may advance faster. People who are taking ART may be in this stage for several decades. While it is still possible to transmit HIV to others during this stage, People who take ART exactly as prescribed and maintain an undetectable viral load have effectively no risk of transmitting HIV to an HIV negative partner through sex. So ito na yung nauso o this is actually what's being advocated now. The U equals U, undetectable is equal or equals untransmissible. U equals U, undetectable equals untransmissible. AIDS is the final most severe stage of HIV infection because HIV has severely damaged the immune system. The body cannot fight off opportunistic infections. So, opportunistic infections are the conditions that occur more frequently in people with weakened immune system, you know, compared to healthy individuals. People with HIV are diagnosed with AIDS if they have CD4 count of less than 200, as I've said earlier, or if they have certain opportunistic infections. And for everybody's information, TB or disseminated TB is actually one of the AIDS-defining illnesses that's been described before. You know? And aside from that, of course, aside from TB, even shingles, no, is also one of those AIDS-defining illnesses have been described, no, that will make you suspect that the patient already has, no, long-term or chronic HIV infection. Once a person is diagnosed with AIDS, they can have a high viral load and are able to transmit HIV to others very easily. So ulit, isipin natin, pag may AIDS ka, mataas ang viral load mo, and therefore the chances of transferring it to others is very, very high, or it's quite easy to transmit it to others. Without treatment, people with AIDS typically survive about 3 years, primarily because of the opportunistic infections that would occur. Again, acute HIV infection. During this stage, rapid multiplication of HIV, virus attacks and destroys infection-fighting CD4 cells. HIV level in the blood is very high, increased risk for HIV transmission. For chronic HIV infection, again, latent yan. Wala silang mga manifestations. Continuously nag-multiply ang HIV and pag walang ART, can advance the age in 10 years time. But of course, if the patient is already receiving treatment, the likelihood of transmission is very, very low because of the viral load is becoming low as well. And this can actually persist, no, for several decades. AIDS, final most severe stage, opportunistic infection set in, and without ART, typically survive about 3 years. So, CD4 plus T cell count is a marker of the strength for a person's immune system. Normal value is around 800 to 1000. The lower the CD4 count, the more severe the HIV infection is. The higher the CD4 count, the better the health status. Now, when we talk about the viral load, is the amount of virus inside one's body. Viral load of more than 20,000 per ml denotes severe infection. But usually, right now, what's defined as undetectable or those without any risk of transmission is less than the viral load of less than 200 per ml. So this is the list of the producing illnesses in HIV infections. I mentioned about disseminated TB, and even shingles, and even Salmonella septicemia. As you will see, these are common in the Philippines. Tuberculosis girovecii infection, cytomegalovirus infection, even disseminated candidiasis, which are common infections that we see even in those individuals with comorbid illnesses, or those who are receiving chemotherapy if they have cancer. But this is again the list, and you have to suspect AIDS as the most likely cause or predisposing cause why they are having these conditions. So for the initial assessment, the interaction that occurs while obtaining the initial history can have a major impact on the subsequent patient or client-provider relationship. Thus, the initial intake should be patient-centered. Multidisciplinary approach with the interview performed in an open and non-judgmental manner. The initial encounter is an opportunity for the clinician to establish rapport with the patient, assess the client's support network. So when we talk about the HIV related, of course, you have to take note of the date of diagnosis of HIV, and if known, the approximate date of initial HIV acquisition. And you also need to identify the risk factors related to HIV acquisition. And of course, this will also help in terms of the overall management of the patient because other sexually transmitted agents should also be, screened or should also be checked. And of course, associated complications related to HIV or even presence of comorbidity should also make you be more aggressive or should make you more aggressive in terms of handling all the other complications that you could expect or anticipate. And it's quite important to review the past records, including, of course, prior medicines that this patient is taking, and of course, if there are allergies, and of course, other really sexually transmitted infections the patient had before, and of course, other chronic medical conditions, babalik-balikan nyo yan eh, para masigurado yun na wala kayong mamimiss because this can compound or can make the patient's condition even worse. And of course, prior history of tuberculosis exposure, if there's a need to screen and treat or give prophylaxis. Um, but in the Philippines, of course, once we have started the patient on ARV, if the patient doesn't have any active TB, we also give TB chemoprophylaxis, no, as part of the regimen. Now, if the CD4 is low, then we also, if CD4 is less than 200, we give PCP prophylaxis as well. Now, going back, you also need to review the immunization history, past surgical history, including complications with or from surgery, psychiatric history. Siyempre, importante, mental health issues nila. And before, when I started looking at patients with HIV, that's mid 2000, around 2005, then I had to train in 2007. Then from then, there start this surge, no? Marami mga bata, adolescents, no? Na diagnosed ng HIV. And you would be surprised that many of these individuals are brought by their mothers, no? And part of our job is really to even advise the mother or the parents, no? Aside from the patient. Now, more recently, of course, the elderly are having problems in terms, I mean, not elderly, but the more senior than the children or the adolescents, young adults or the middle adults have a higher difficulty of coping, no, or accept or get or accepting, of course, what they have, particularly with HIV, and therefore we need to, of course, part of our job is really to evaluate and assess them whether they need psychological or psychiatric help. No? And of course, we need to look at, of course, how what's their social behaviors and if they're frequently traveling. And of course, part of our job is again come out with a get a very detailed, history or information about the patient. For the physical examination, complete, should be done at the initial encounter with particular attention given to the oral, integumentary, and lymph node. Sorry. Because it's quite important not to miss anything. The presence of rashes. Again, balikan ko sinabi ko kanina sa STD. So, be careful. Look at the palms, of course, and the patient's soles. You might be also dealing with a confounder, which is syphilis on that particular HIV patient. Okay, and part of our examination is check, of course, the anorectal area, aside from the genitourinary or the genitals. Neuropsychiatric examination also a must, no? So that again, we can properly assess the mental cognition or the mental status of our patient, whether they are depressed or not, or if they have suicidal tendencies. Okay, and do not forget, of course, I forgot to mention about alcohol habits or even smoking habits. Drugs, of course, very very important. Now, moving to the recommendations given by the Philippine Guidelines on Periodic Health Examination, we are part of the group that uh, came out now with these recommendations, screening for infectious diseases. We released this 2023, and this is actually being updated regularly every year. Though right now we don't have any update yet. And the considerations when it came out with the recommendations include the screening, for HIV among asymptomatic, particularly healthy adolescents and adults. No? The panel maintained that HIV screening is multidimensional and psychological harm of screening should be considered, especially among individuals who are at low risk for HIV infection. Now, the panel further emphasized that physicians should identify a compelling reason to request HIV screening for low-risk individuals, and the teen screening will also be costly for those who do not really need to undergo testing. So, HIV for asymptomatic, apparently healthy adults recommend against routine screening. So, do not forget, get a good history. Make sure that you don't miss anything, particularly sexual activity or behavior of patient. The preferences, yeah, the patient might be silent. You have to develop the rapport, really, to come out, and get a very good history. So for screening, the target population usually is MSM, people in prisons and other closed settings, people who inject drugs, sex workers, and transgender men and women. So for HIV, high risk asymptomatic apparently healthy adults, we recommend HIV screening using a rapid diagnostic test. So these are the high risk population. So adolescents, high risk individuals who have not been tested recently, partners, infants, children, people living with HIV, those showing signs and symptoms such as AIDS, defining illnesses, those with sexually transmitted infections, those with hepatitis B and C, undernourished, not responsive to interventions, all confirmed TB patients, all pregnant women, regardless of risk. So most common testing strategy, one-time testing for low-risk individuals and low-risk prevalence setting, or those settings with less than 1% HIV prevalence. In high-risk individuals, testing frequency of every 3, 6, and 12 months. Now, the overarching goals of HIV testing services are to identify people with HIV through the provision of quality services for individuals, couples, and family. Kailangan ang mindset open. Dapat hindi kayo judgy. And we should effectively link individuals and their families appropriate HIV treatment, care, and support, as well as HIV prevention services based upon their status. And also, the HIV testing services are to support the scale up of high impact interventions to reduce HIV transmission, morbidity, and mortality, and that includes, of course, ART, voluntary medical marriage circumcision, prevention of mother-to-child transmission. So part of it is, of course, screening pregnant individuals, and the PrEP and PEP, or pre-exposure prophylaxis and post-exposure prophylaxis. To be honest, dati, because of our culture, I'm not actually inclined on promoting the PrEP. Primarily because I believe before that it would just actually promote sexual promiscuity. However, after or during and after pandemic, I realized that there are high risks, particularly with what we have now, the easy access with the internet, the easy way of getting in contact with people we don't really know, and therefore, aside from, of course, promoting the use of protective measures like condom use, we also now promote, and advocate pre-exposure prophylaxis, particularly among high-risk individuals. In the Philippines, HIV testing remains focused among, of course, those populations. No? Barriers to HIV testing among Filipinos included HIV-related stigma, so misconceptions about the virus, fears of testing HIV positive, and financial instability. Takot eh. And I think that's also the reason why before 2007, there was really low prevalence of HIV in the Philippines. However, since that time, tumaas at ngayon mas mataas na, especially because of the availability of self-testing kits. No, the biggest dilemma or difficulty with the self-testing kits is we don't know how these people who are testing themselves would take it, especially if it becomes positive, if they would not actually submit themselves for treatment, or if they will do something that's harmful to others. Therefore, part of our job really is to do proper counseling to all individuals, particularly those who are at high risk, rather than just promoting the self-test kits. Yes, it can enhance diagnosis. It can facilitate, of course, more people getting diagnosed with HIV. However, we want to make sure that these people are properly addressed and handled. No? And also the biggest problem with the testing is many patients still don't want to get tested, particularly if they are symptomatic, and therefore continuing education is certainly a must for all. And I mentioned earlier that the key population of partial pregnant individuals must also be targeted, and and we must of course recognize that the government has already laid plans on how they can actually provide the medicines for free. And a good thing now, that's the recommended WHO recommended regimen. That's the tenofovir, lamivudine plus dolutegravir are available here in the Philippines. No? And that's actually what we are now giving. And the side effect is much lower than before with the efavirenz in use. No more psychiatric or no more insomnia related to efavirenz. And of course, these are also safer, a lot safer. The only problem is many are now getting obese, or should I say, gaining weight, no, because of this regimen. When we talk about HIV testing, we have to remember the 5 C's. The principles that we have to, of course, remember include consent, which is the informed consent that we need to get or we need to obtain from the individuals getting tested. Now, verbal consent is sufficient. Written consent is no longer required. They should be informed of the process for HIV testing and counseling and of their right to decline testing. So though it's no longer required, but still, written consent might be a good one to help you to save you from, of course, some problems later on. But again, let me emphasize, verbal consent is sufficient when we talk about consent, no? And maybe to follow na lang yung written consent, if, especially if they understand, of course, the process, as well as whether and what to do next in case they are found positive, or even if they found themselves negative. Now, in terms of confidentiality, that's the next C. The HIV testing service must be confidential, meaning that what the HCS provider and client discuss will not be disclosed to anyone else without the express consent to the person being tested. Confidentiality should be respected, but it should not be allowed to reinforce secrecy, stigma, or shame. Counselors should discuss, among other issues, whom the person may wish to inform and how they would like this to be done. Shared confidentiality with a partner or family members, trusted others, and healthcare providers are often highly beneficial. So, yan ang isa pang issue sa atin dito sa Pilipinas, yung confidentiality. Takot din eh, kasi baka kumalat, no? But certainly, we just have to emphasize, no? Everything will be treated with strict confidentiality para hindi sila matakot. Kasi importante rin na masigurado kung meron sila o wala. In fact, that will make them feel better if they are high risk and yet they are negative. But we just have to emphasize the goodness of proper sexual behavior and using protection as often as necessary. Now, counseling is the pretest information that should be provided, but and this can be done in a group setting, but all people should have the opportunity to ask questions in a private setting if they request it. So, pag individual, better, siyempre. Pero pag group, pwede din. Also, HIV testing must be accompanied by appropriate and high-quality post-test counseling based on a specific HIV test result in HIV status reported. So, kung positive, dapat ipapaliwanag pre-test pa lang eh. Kung negative, papaliwanag din kung ano next na gagawin. Pero siyempre, pagka lumabas ng result, meron uling counseling kung negative o positive, kung ano yung next na steps na dapat nilang malaman at dapat nilang gawin. Quality assurance mechanisms as well as supportive supervision and mentoring systems should be in place to ensure the provision of high-quality counseling. Now, correct means providers of HIV testing should strive to provide high-quality testing services, and QA mechanisms, so quality assurance mechanisms, should ensure that people receive a correct diagnosis. Siyempre, yan ang ayaw natin mangyari, yung ma-misdiagnose sila na meron, yung pala wala. And kaya yan din ang reason kaya madalas kung meron ng slight reactivity or reaction test, nadidelay yung result. Or in fact, there should always be confirmation. The process actually requires repeated testing right now to make sure whether the patient indeed has a positive result. However, if from the onset nag-react na agad, then the patient should always be advised on what to do next. In fact, we advocate early treatment now rather than wait to for the CD4 to go down below 200 before treating. The earlier treatment, the better. Okay? And all people who receive a positive HIV diagnosis to be retested to verify their diagnosis before initiation of HIV care or treatment. And I think I have to emphasize that. And then connection, linkage to prevention, treatment, and care services should include effective and appropriate follow-up, including long-term prevention and treatment support. Providing health HIV testing service as per there's no access to care or poor linkage to care, including ART, has limited benefit for those with HIV, and therefore continuing linkages, continuing contacts should be maintained. Ako, I don't usually give my numbers to all my patients except for HIV patients, particularly those who have had opportunistic infections before, because I need really to make sure that they follow up well and they adhere to the ARV treatment, no? Kasi gusto ko masigurado na hindi sila nawawala. Madalas before, maraming nawala eh. And it's now good. A majority or almost all of my patients now are adhering and they're continuously follow up and letting me know through email, even by phone, by Viber messages, which are free, on what their status now and what they're doing now. Now, barriers to HIV testing. Again, let me repeat the HIV-related stigma, the misconceptions about the virus, the fear of testing positive, and financial instability. For, of course, MSM barriers, we have the perceived risk due to absence of symptoms. So, tandaan natin na yung clinical latency na matagal. Pag hindi naman na-treat, mabilis din mag-AIDS. Feeling morally superior, higher socioeconomic class, inaccessibility to testing facility, uncertainty of treatment side effects, fear of HIV-related healthcare expenses. Again, right now, we have good services. We give or provide the medicines ARV for free through the DOH or government. And the side effects are very minimal. And the only thing that we need to watch out for is, of course, weight gain. And that has been reported recently in the AIDS conference that I attend to. That obesity is now a common problem among those who have long-term HIV receiving the current regimen, the tenofovir, lamivudine, and dolutegravir. And of course, usually the counselor should be certified, no? Uh, based on the Philippine AIDS Prevention and Control Act, that's 1998. Uh, and of course, recently in 2018, the provider can initiate the counseling and testing as well, especially now because there is this self-testing kit. Meron kami sa clinic na eh. But of course, this can also be used in some of the hygiene care services that are available nationwide, not only in Metro Manila. Now, before, parental consent for HIV testing among those less than 18 years old is required. No, now right now they have lowered down, of course, the testing to ages 15 to 17 years old without parental consent. But for less than 15 years old who is pregnant or engaged in high-risk behavior with assistance of a licensed social worker or healthcare worker, within the den, now consent from a child's parents, legal guardian, if the person is less than 15 years old or mentally incapacitated. So as I've said earlier, right now, ang testing, repeat testing na lang, no? Wala na yung confirmatory test kagaya dati na may Western blot pa. Dati kasi meron eh, bago ma-confirm, ang tagal, no? Ang tagal mo antayin. Kaya ang hirap kasi rin noon, nung araw. It was more than a decade ago. Na kailangan talaga antayin, tapos ayaw mo namang i-startan kasi may mga side effects yung gamot, no? And usually, pag ni-refer pa sa reference lab, bago nire-release result, ang tagal talaga. Minsan nawawala pa yung papel o nawawala. And so, in 2019, ito na mas mabilis, no? The Philippines started to transition from the use of Western blood test for HIV confirmation to the rapid HIV diagnostic algorithm, no? Involving the use of three rapid diagnostic test kits to confirm HIV diagnosis. So just look at the figure on the right. Now, this approach decentralized confirmation of HIV diagnosis from couple reference laboratories in Metro Manila to the 38 certified um, uh, rapid HIV diagnostic algorithm confirmatory laboratories around the country. And this significantly decreased waiting time for HIV confirmation and facilitated linkage to care from weeks to days. No? So, ulit-ulitin lang yan eh. Kung titingnan yung figure sa kanan, one rapid test, if it's reactive, then refer to certified RHIVDA confirmatory laboratory, then this will be repeated. If it's reactive, repeat. If it's reactive, repeat. Then pag reactive pa rin, HIV positive siya. So, mas mabilis yan kasi hindi na kailangang paggawin pa yung Western blot na ang tagal-tagal ng resulta. And therefore, mas mapapabilis din yung treatment, mas mapapabilis din yung pag-aalaga at paggabay. So, meaning, it's quite important for us really to guide them properly. Okay, but if the report is inconclusive, we can just have to send another sample and have them recheck. Particularly, and then this can now be uh, transported to the National Reference Lab. So, for baseline, of course, confirm HIV diagnosis and then CVD4 cell count with percentage. These are excellent indicators of immune function, estimates individual risk for HIV-associated complications. Pag less than 200, PCP, pag less than 100, isip ka ng mga CMB, tsaka ng mga iba pang mga opportunistic infections. No? MAC, of course, should be considered if there is the CD4 is less than 50. The percentage is less variable than absolute count. Now, quantitative plasma HIV RNA level or sa viral load can be done at entry into care. HIV RNA level directly proports to disease progression. So the levels more than 100,000 copies impacts efficacy of some ART, and this viral load lower limits of detection thresholds 20 to 50 copies per ml. Kanina nabanggit ko nga, pag less than 200, pwede nang i-consider na undetectable, and that's related to being untransmissible. Now, if there is a slow decline or if there's again an increase, then you might need to perform HIV genotypic drug resistance testings and check whether there is, of course, some problems, no? The presence of HLA B5701 and because this can identify individuals at high risk for abacavir hypersensitivity reaction. It's good now that abacavir is not routinely given or not frequently given because of the availability of the current regimen that we usually use or give to our patients. Of course, don't forget to check for women the pregnancy test and G6PD deficient testing. Now, additional baseline testing for CBC with differential, basic chemistry panel, calculate the creatine clearance, ALT, AST, urinalysis check for proteinuria, which can be HIV-associated nephropathy. Check for lipid profile because you have to monitor this also when you start administering the ARB. Check for fasting glucose or better the HbA1c, especially if there's family history of diabetes. Check for serum testosterone for monitoring gender affirming care. For co-infection comorbidity, check for CMB. As I've said, no, retinitis can be common if CD4 is less than 50. Even the possibility of this CMB disease can occur if the CD4 is less than 100. Now, HIV should also be checked along with HBV. And then HCV, which can also be sexually transmitted, aside from being related to blood transfusion, should also be checked. They should be screened for Mycobacterium tuberculosis, check whether it's active, check for toxoplasma, also related to CD4 count less than 100, and most importantly, check for other sexually transmitted infections. Now, right now, I think there are more than 200. No? Sorry for not yet replacing this, but this is based on the reference published in 2023. I think there are now more than 250 treatment houses of HIV care facilities nationwide, and ARTs dispensed through these facilities. Remember, again, ARTs are free, other fees for Medicare covered by PhilHealth, and the good thing now with PhilHealth, they have increased the annual reimbursement fee. And therefore, for as long as we maintain confidentiality, everything is kept secret. No? Hindi sila dapat matakot na nag-avail sila ng PhilHealth benefit because lahat yan nakatago, hindi yan nilalabas ng mga HIV care services, including us, no, na tumitingin sa kanila. So one is, just remember, I think we need to emphasize this to all our patients. Once ART stopped, viral load rebounds. No? We should not allow these patients to skip more than 3 days. Worse if they have skipped the drugs more than 1 week because the likelihood of resistance is quite high, particularly if they have uh, maintained or have not actually changed their behavior in terms of sexual activities. So to achieve plasma HIV RNA suppression, ART should be continuous, and they should always adhere to the right timing as well as the intake of the ARV. Okay? And just remember, kahit na target natin maging undetectable sila o 20 to 50 or less than 32 or less than 44 depending on the laboratory, it does not completely eradicate the virus at reservocytes. No? Ngayon, nabanggit ko nga kanina, the latest medicines that we are giving is now tenofovir, lamivudine, and dolutegravir. That's the T, D, and F, no? Or LTD. So wala nang efavirenz, wala kasi maraming intolerant dyan eh. And they say now, and we have seen that this have become more effective, no? Better tolerance. The only problem is, of course, the obesity or the weight gain. And the likelihood of genetic resistance is also low, with dolutegravir. The only problem is, of course, if they have TB because of the interaction with dolutegravir and rifampicin, because you might need to double the dose of dolutegravir. And right now, DOH does not have a single formulation of 50 milligrams dolutegravir, which is combined with the tenofovir and lamivudine. No? And therefore, we still coordinate with a private company so that the patient may now buy this additional dolutegravir in case they actually need to take rifampicin. Rifapentine, which is an alternative that can be taken once a week, can also interact with um, dolutegravir. Rifabutine is the only comparator or the only alternative to rifampicin that has no interaction with dolutegravir. Okay. Another challenge is, of course, I think all of you must know that Philippines still a high prevalence of hepatitis B. And I think this is still the same, roughly, that's still more than 15% in the general population up to now. So, just to motivate them, encourage them to adhere, U equals U, associated improve overall sexual mental health, medication adherence, viral load suppression, and this can also destigmatize them. In fact, many of my patients now I encourage them to have babies. For as long as they will mention or they'll tell the partners that they have HIV and they're taking their drugs and they are undetectable, and provide the partner the proof, that they are undetectable the latest, when they check their viral load. And certainly, aside from HIV, pregnant individuals should also be screened with syphilis and hepatitis B virus. There's now a triple simple test, that combines all these three: syphilis, HIV, and hepatitis B, that can be done, in pregnant individuals. Remember the ABCs of prevention: abstinence, being faithful, condom use. But of course, do not forget vaccination. Among MSM, several reasons for not using condoms were trust in one's sexual partner, diminished pleasure, and unavailability of condoms. Among heterosexuals, condoms were perceived primarily as a birth control measure rather than as protection against HIV and sexually transmitted infections. Other barriers identified were stigma associated with purchasing condom, as it is associated with premarital sex or infidelity. But of course, just remember, mas importante talaga may protection. No? If you cannot be faithful, if you cannot abstain and be celibate, then use condom. So, thanks for listening. If you have questions at nahiya kayo, you can just email or send your questions via email. That's my UERM email address. So, but if you have questions, just feel free, and then just you can type your questions in chat box, and I'll be answering them. Thank you.
Thank you po, Doc.
Yeah, wala kayong tanong? O meron? G. But again, you can just email me your questions if you would like to clarify anything. May pinadala ko yung PDF file, kasi nag-overlap yung mga slides, and there are, of course, some errors with what I was saying. What I was saying earlier, parang nagkakaroon kasi ako ng, dahil nung binabasa ko yung slides, magulo rin kasi yan nung napasa sa akin. So, kaya nagalaw ko rin yan. Kaya nagkaroon talaga ng overlap when it was uploaded sa Canvas. Doc, clarify ko lang, LTD na po ang gamit natin for treatment? Yes, definitely yes. And that's good because that's the one recommended by the WHO. Remember what I said in the lecture that I recently attended the AIDS conference, in Africa. That was last month, It's been widely used, globally, and the adherence is quite good. And of course, the viral load suppression is definitely much, much better than before, Kasi dati talaga maraming side effects, and main reason why several patients did not comply as well as did not continue the medicines were the side effects, as well as, of course, the difficulty in terms of getting the supplies, kasi mas mahirap pa mag-supply before. But right now, these are being given by the government. So LTD is lamivudine, tenofovir, and dolutegravir. Any other questions? Anyway, thank you very much for listening, and I hope that you can again look at the PDF file. Teka, Doc, yung pong for staging of HIV? Is it the CD4 level po by the CDC or by clinical manifestation? Both, actually. Usually, we also look at the presence of opportunistic infections. There's a reason why it's automatic that they're labeled as having AIDS if they already have opportunistic infections, even if we still don't know the CD4 count. But of course, if the CD4 count is less than 200, then that also will be synced, of course, with the presence or absence of signs and symptoms related to AIDS. No? And therefore, both yan, clinical as well as CD4 count. Anything else? Anyway, it's already 4:53. Again, don't forget my email address. If you have questions, just send them to me. Thank you again. Thank you to all for staying and listening. And again, see you and good luck on your exams soon. Thank you.
Thank you, Doc.
You know,
Thank you po, Doc.